All right, friends, we've officially made it. Episode 10. We got Crack the Chest, the evolution of chest tubes.
Yeah.
And if you couldn't imagine, we're talking about the chest.
It does flow nicely, though, from our previous episodes.
I agree.
Yeah.
I
So
agree.
I think it'll flow right in.
Flow right in.
Right in. We are not flowing today.
We're not. We'll get there.
We'll get it. We'll get it. Here we go. Here we go.
All right. Welcome, Cadaver Crew.
Get your dark little minds right and settle in.
Class is in session, and the cadaver is already on the table.
I'm B.
And I'm Sam.
And this is the Cadaver's Lessons.
Yeah, so as we talked about or kind of alluded to already, we are talking about the chest wall. Specifically, we're going to be talking about more the lungs and the pleural space and how we can help in emergencies, which is still widely used today. So very important. But I think we'll find that the history of how this came about is super interesting with some questionable pieces, not as questionable as some of our early episodes, but still some questionable pieces a part of it.
Yeah, it definitely gets interesting and a little gross. We'll get to it, though. Vitals check. How are we doing?
We're doing okay.
Yeah, we're doing okay. Things are on the up and up. I guess when you start so low, it's like you can only go up from here.
When your whole month of January was a voodoo doll being stabbed over and over, February feels pretty good.
Yeah, it feels pretty good so far.
Yeah.
We've been watching the Olympics.
Yes, been very interested in it. I have to say, though, me and the other ER providers are very concerned about the skeleton and how fast these people are going head first down this ice.
Yeah, even your helmet can only protect you so much.
I agree.
Yeah.
I agree.
I don't know about you guys, but curling, I kind of like this sport.
Do you?
It's kind of cool.
Yeah. I've been more into the cross-country skiing with shooting. And then if you miss a shot, you have to take like this penalty lap. And so, yeah, it's been brutal but fun to watch.
Yeah, that's brutal. Yeah, I haven't really gotten to watch a lot of figure skating. I'm usually a big figure skating person.
Any interest in the figure skating?
It's so cool.
Man. Okay.
Yeah, but anyways.
Right. Not all of Sunshine and Rainbows, though. Couldn't figure out why our kid wasn't sleeping. You just chalk it up to like one sleep regression after the other. And you're like, yep, here we go again.
Every time you Google, why is my kid not sleeping at this many months? It'll be like sleep regression.
Yes.
And it's like, okay, that can't be the answer for everything.
So we took her to her first dentist appointment, which just happened to be like at this time. And the dentist goes to feel in her mouth and she was like, all 4 molars are coming in at one time. I said, oh, that's probably why she hasn't been sleeping. And they were like, for sure why she hasn't been sleeping.
Duh.
So nothing a little ibuprofen won't fix.
Yeah, poor baby.
We forgot to give her some of that before bed last night.
She slept through the night, though.
You went in there?
At 5 in the morning.
Okay.
So what happened in the ER today, or this week?
This week, I, interestingly enough, had 2 cases of pneumomediastinums. So if you're not familiar, pneumomediastinum...
First of all, what the fuck is that?
Pneumomediastinum, tons and tons of air in the chest and can very quickly become an emergency for patients. One big concern, which was a very real possibility in my first patient that had it, is something like an esophageal perforation secondary to trauma, vomiting so much, things like that. And of course, my first patient that came in this week with it, and I had never seen it before, but had been vomiting blood for 36 hours straight, had filled like trash cans full of blood.
Ugh.
And was the absolute perfect case, like alcoholic, everything for this to be the real emergent pneumomediastinum. I got that call from radiology about 15 minutes after she went to CT scan. And I was like, oh boy, they're going to tell me there's an active bleed. And they just called me and they were like, have you seen how big her pneumomediastinum is? And I was like, no, to be honest, because I have another patient I'm about to intubate and we have another patient that just came in having a STEMI. So I have not looked at any imaging whatsoever. And yeah, they were like, we are very concerned. And I was like, oh, cool. I am concerned now too. And then I just had one last night that was a pneumomediastinum in another case of an alcoholic going through alcohol withdrawal and vomiting. Luckily, he wasn't vomiting any blood. His was only mild and his was also negative for esophageal perforation. So, but fun stuff. Something I'd never seen personally in my career before, but something that makes you nervous when you see it. And then I saw 2 in 1 week. B's parents or my in-laws brought donuts to the hospital after our little brother came and shadowed me for a little bit. And I never realized the way that we tell people, the whole department, that we have food is probably different than most people.
Yeah, usually in a normal job, you just say, hey, there's food in the break room.
Yes, but you'll miss so many people doing that, and also it takes so much time to get through the whole department saying that. And so we actually make an overhead all-call page that says GI consult to the break room. And I'll be honest, the first time I heard this when I was working there, I was like, oh man, hope they're okay in there. And like didn't think anything of it. And then about the third time I heard it, I was like, this means something. And then I realized it means we have gotten free food and it is in the break room.
Yeah. Yep.
Yeah.
So on the podcast side of things, we have 450 streams.
We're actually much past that after the last 24 hours.
Yeah.
Yeah.
So that's wild. And that's all because of you guys.
Yeah. Yeah. Something worked with our HIV series.
Yeah.
Once again, we record multiple weeks in a row. So today we're recording after we just ended our HIV series being published. It did really well.
Mhm.
It's doing really well on social media. And we keep talking about like, at what point do we get excited? Because our streams are exponentially growing right now.
Yep.
And 450 streams isn't a ton, but for like how small we are, it is a lot. And we're like, at what point do we get excited?
I know.
I don't know.
It's exciting.
It's exciting.
Yeah.
Yeah.
It's exciting that you guys seem to like it. And so we're excited to keep doing it.
Yeah. And then speaking about the HIV and transfusions, on one of our videos from this week that we posted as a clip from the podcast, somebody had responded saying that their son has hemophilia and they do HIV testing after every blood transfusion because of the fear of transmitted diseases in blood transfusions, and just thanked us for, spreading that information so that people can be more aware of it. And it makes you feel good, like this is stuff that people don't talk about a whole lot and like to shush under the rug. And it's really, I read that comment and I felt good about what we've been doing.
Yeah, I think it's a valuable, we like to have fun. We like to talk about some dark stuff in history and bring up some brutal case files and then talk about some maybe more comedic things as well. But I think overall the messaging is good, and you learn a little something, even if you're doing this while working or doing it while walking or doing the dishes or whatever. At least you pick up a little bit of something and learn a little bit.
Yeah.
I've learned a lot.
I've learned a lot, and I've become a more nervous provider because of it.
Nervous.
All right.
Let's get started. Yeah.
Chest tubes. What are they? So a chest tube is what we call a thoracostomy, is the medical term for it. But even in medicine, we typically just call them chest tubes. And the chest tube is a hollow, flexible tube that's inserted into the chest in the pleural space. What is the pleural space?
That's a good one to know.
Yes.
I know that one.
Got to know it for today's episode.
Yep.
So the pleural space is just the definition of the space that's in between the lung and the chest wall. So that open space that's right there, that's what we consider the pleural space. Typically, speaking specifically to chest tubes, it is placed in between the fourth and fifth intercostal space at the mid-axillary line. Sometimes they go a little anterior to this, but a great spot is the fourth and fifth intercostal space at the mid-axillary line. In males, this is the nipple line, and in females, this is the inframammary fold. And so if you are like me and somehow suck counting in between rib spaces still in your career, that's a great place to start. And then we'll get to this, but if you're ever questioning it, you should go one above where you think, if you're like, could it be this one or this one? Because it's better to go one above than it is to go one below and hit some sort of abdominal thing. And then, have your patient bleed out. Bad things.
Don't do that.
Why are we doing chest tubes? A few different indications, one of which is a pneumothorax, so a collapsed lung, which we kind of talked about last episode, and that is air between the lung and the chest wall in that pleural space. There are 3 different types of this. There's spontaneous, and that happens without injury. And we talked about this before, but your pathognomonic finding is this tall white guy who smokes. Yes, marijuana and vaping count. And it happens without any underlying pathology that we know about. Then there's a traumatic pneumothorax, which happens due to a chest injury, which you can imagine. This can be because of a rib fracture, a car accident, a penetrating injury. And then your super scary one is your tension pneumothorax. And this is a life-threatening emergency. Air builds up, but is unable to escape. And this compresses the heart and the opposite lung because as the air builds up, it just continues to push and push and push against it. First line for this is not a chest tube. It's actually the needle decompression, which is what you see when people place it closer to the front of the chest wall in between, is it the second and third? First and second and third? I think it's second and third. Second and third mid-clavicular line, you insert a needle into there, take out the catheter, and let the air have a way to escape. There's also a hemothorax, which is an accumulation of blood in the pleural cavity. This is typically due to trauma. pleural effusion, which is an accumulation of excess fluid in the pleural space, which can happen for lots and lots of reasons, which we are not going to get into today. And empyema, which is a collection of pus and bacteria within the pleural space. This can also be life-threatening. As you can imagine, it's very bad to have pus so close to your lungs. Yes.
Not a good spot for it.
There's too much in the chest cavity for this to get close to. And then lastly, there is the chylothorax, which is an accumulation of lymphatic fluid in the pleural space, which I had actually never heard of before this podcast. It is rare, but I guess when it happens, it's super serious. So quick rundown on chest tubes and their indications.
Yeah, that was good because we're going to be saying a lot of those words here in the history because they got to figure out what all of those are.
Yes.
At some point. So that's good. Plus the understanding the pleural space, I think is helpful because sometimes when you're just watching TV or you're reading about it, they just say like, stab it in here.
Yeah.
And you're like, oh, does it go in their lung or does it go in?
No, we are not trying to puncture lungs.
Yeah, exactly. So it goes in between. Okay, so let's talk about the origin story of chest tubes. The oldest known reference to thoracic drainage dates back to the 5th century BCE, and you guessed it, Hippocrates.
Our guy is back.
Yep.
He's back.
Yep.
Listen, I don't know if this guy's really this smart or if he's taking credit for other people's work.
I don't know.
Like, how the hell
did
he figure out this much?
It kind of feels like a group project and his name is just all over it. Yeah.
How is he dedicating so much time to so many things?
Right. I don't know. Maybe it's not like he didn't get to travel.
I don't know.
Really far. I don't know.
Yeah.
Maybe we just need to do a whole episode on Hippocrates and
maybe.
Yeah. Maybe that would be good.
Yeah.
Yeah. In his text, Hippocrates described empyemas, that they could occur in any part of the body, though they were most commonly described in the thorax.
I want to know how they know. Because I know because of a chest x-ray.
I think they know by somebody saying, oh, I can't breathe, and them sticking something in there and draining
Pus coming out.
Yeah, exactly.
Okay.
So as kind of Sam talked about, when we're talking about an empyema, it's the accumulation of pus and infected fluid in the pleural space, the area between the lungs and the chest wall, usually spread by bacterial pneumonia.
Yeah.
So I think this is kind of the first time they're talking about that pleural space, and pus accumulation is the thing that they're recognizing, which kind of makes sense because you're getting an infection and then they're draining that infection. That makes more sense to them than like chest wounds and things like that. So I think that's why we're seeing this first.
Yeah.
Yeah. So the first line treatment was medication of plant material and physiotherapy exercises. But if that didn't work, then...
I'm sure it didn't.
Yeah. I'm sure that didn't go well. Then open evacuation was performed. So
what does that mean?
I'm going to tell you. Here's a common translation from Hippocrates' procedure. There's a few translations in here, and I'm like, get your old English right.
Get it together.
Get your mind right. So, first cut the skin between the ribs with a bellied scalpel, then wrap a lancet with a piece of cloth, leaving the point of the blade exposed a length equal to the nail of your thumb, and insert it. So like this long. When you have removed as much pus as you think appropriate, plug the wound with a tent of raw linen and tie it with a cord. Draw off pus once a day. On the 10th day, draw all of the pus and plug the wound with linen. Then make an infusion of warm wine and oil with a tube in order that the lung accustomed to being soaked in pus will not be suddenly dried out.
I have a lot of thoughts.
When the pus is thin, like water, sticky when touched with a finger, and small in amount, insert a hollow, thin drainage tube. When the cavity is completely dried out, cut off the tube little by little and let the ulcer unite before you remove the tube.
Okay. My first thoughts.
Yeah. Tell me your thoughts on that.
My first thoughts. 10 days of letting this drain out. These patients are septic as shit by this point. There's no way they're not septic by now. How is this working? B, we're leaving this open without any sterile bandaging, anything like that. They got to be getting sicker.
Well, you get a little tent, a linen tent.
There has to be secondary infections because of this. 3, I won't lie. I then started thinking about how many leeches do you think were used in this?
Yeah, probably a lot.
Yeah.
Yeah, so he left the drain in place for up to 2 weeks and was able to successfully treat inflammation with this procedure.
Wow. A lot of people had to have died.
There's
no way.
Oh, yeah. I mean, when you say able to successfully treat inflammation with this behavior, it's like how long did the person live after that?
And what's your success rate?
Yeah, exactly.
We're talking about like 1 in 100?
Right. Exactly. Yeah, just interesting. That's how they were kind of just letting it drain.
Yeah.
Yeah. Over days and days.
I mean, we keep chest tubes in.
Yeah.
I want to be clear, and we'll get to that down low. But we keep chest tubes in, so much more going on to protect the patient.
Later on, Galen, who we mentioned early on in these episodes that Hippocrates has been in, he's like the second guy coming along, would describe a similar procedure for abdominal practices, but does not comment on thoracic injuries. So this is really just Hippocrates and what he's doing. It didn't really catch on with Galen. And then the next recorded account of removing pus to heal a chest wound was documented in the text of Medicine in the Crusades.
I just want to say, I think it's super cool that Galen was using something for like abdominal abscesses. We do it under interventional radiology, not through things like tubes, but under very guided procedures, go in and try to drain abscesses when possible. And so how cool that they were doing it this long ago.
Yeah.
I mean, still probably not a good time, but
people were probably not having a good time.
No.
Yeah. So in this text, Medicine in the Crusades were much, much later than Hippocrates.
Yes.
A lot later.
Yeah.
Okay. So described by, this is also, all of these people's names reminds me of like Game of Thrones.
Yes.
Because all of their names are name of a place and they're all knights and things like that. So described by Albert of Aachen, recounted by Gubert of Nogent.
Strong names.
Yep. Baldwin the First of Jerusalem, who was alive between 1058 and 1118, long time ago.
Yes.
Was struck by a lance. His treatment that involved draining pus from the wound was based on an earlier experimental treatment of a bear with a similar injury. Yeah, so they tested it on a bear.
Okay, I mean, I guess it's great that they did some sort of experimentation before doing it on humans.
Yeah, I don't know if it was, well, we just stabbed this bear in the chest. Let's see.
Yeah.
See what we can do about that.
Seems like some animal cruelty, but
yeah,
we'll close our eyes to it for a minute.
So there's no other descriptions of this type of procedure during this time, implying that it was not widely known or practiced at this time. So we see it in Hippocrates, and it's kind of interesting that he has text on it, but then we don't see it again, really. It's developed slowly through battlefield injuries.
Mm-hmm.
So something that could cause this is, as we talked about before, literacy rates.
Yes.
People just didn't know, and people didn't have access to the text, and they couldn't read. And so they're still figuring this out on their own. It's not like having full access to the internet and being able to just look it up if you have a problem.
Yeah.
Yes.
No chat GPT in these times.
No. Could you imagine? Oh my gosh. What would they look up?
I mean, their knowledge would be so advanced if they had that.
That's true.
They would look up what we're looking up.
What if you just gave it to them? Hey, guys.
Like, ran back in time.
Yeah, I know you can't even write, but can you type onto this? What would you ask it?
If you could ask one question, what would you ask
it? Exactly.
I'll type for you.
So the actual first clear mention of a tube thoracostomy procedure was written in Parzival by Wolfman von Eschenbach between 1210 and 1220. Sorry, sometimes these dates, they get me.
Because they're so
Yeah.
I mean, this is only 1,000 years ago. No, it's 2,800 years ago. No biggie.
That's a long time. Okay. In this writing, he described a knight named Gawain's actions on encountering a fallen knight named Uriens, who then sustained a chest wound in a joust. Yeah, a little jousty joust.
Listen, I gotta say, they had to have plenty of chest injuries to practice on.
Oh, yeah.
Plenty.
Oh, yeah. So in this text, here's another one where I gotta get my mind right to read it. There lay a man pierced through with his blood rushing inward. I could keep this knight from dying, and I feel sure I could save him if I had a reed. You would soon see him and hear him in health because he is not mortally wounded. The blood is only pressing on his heart. He grasped a branch of a linden tree, slipped the bark off like a tube. He was no fool in the matter of wounds, and inserted it into the body through the wound. Then he bade the woman, where'd she come from? Woman to suck on it until blood flowed toward her. The hero's strength revived so that he could speak and talk again.
Don't tell me we're about to start sucking on wounds.
Yeah.
Stop it.
Oh, yeah, we are. You were worried about sterility before?
Now we're...
I'm sorry, guys. Wow, that was... Ugh, gross. So, blood pressing on the heart could be interpreted as pericardial tamponade, suggesting that the knight sustained a rib fracture which caused a tension pneumothorax, and they treated it through building a little tube out of some bark.
Yeah, this guy died, for sure.
This could have been a well-known treatment on the battlefield, but not necessarily in medical text, especially since surgery was a lucrative and secretive profession. So, like I said, only some people could read.
Mm.
And so if you were a surgeon, you wanted to keep that to yourself because people paid you a lot of money to know that kind of stuff.
But doesn't it make you so mad? Like, you do not know less because you let others know more.
Right.
This is not a competition of who can keep more people alive. But it was.
But it was.
Yeah.
Yeah, it was exactly that. So then in 1395, there starts this debate of open versus closed treatment of thoracic wounds.
Closed wins.
So
not for a while, it sounds
not
like.
for a while,
but
because it goes back and forth for a long time.
Yeah.
Long time. So this guy, this guy, named Guy, Guy Chuelic, leading physician surgeon of medieval France, completed a text called Chirurgia Magna.
And what was that text?
I'm going to tell you. I just had to get over pronouncing it. He notes in this text the lack of ancient text on thoracic wounds and discusses the common disagreement on treatment, where some believe penetrating thoracic wounds should remain open with tents and drains to allow blood and decaying material to escape, while others argued wounds should be immediately closed to prevent cold air entering and loss of heat.
You know, what about bacteria?
What about a lot of things?
Yeah.
A lot of things.
Lots.
He then recommended the following for treatment of penetrating thoracic trauma. 1, the use of a tent, installation of warm wine or a honey and river water mixture.
Okay, I could really get on board with the honey because it actually has great properties. But some river water, come on, brother. We can't do that.
They don't got sterile water.
We can't do that.
I guess they have boiled water.
There's no way you look at that river water and say, clean.
Well, not nowadays, that's for sure. That's for sure. Patient rotation was another part of that practice. Measuring drainage for 4 to 5 days. So actually measuring how much is coming out. If fluid decreased and remained clear, irrigation stopped. The tent remained and the wound was dressed in cotton. If no improvement occurred, retained material upon the diaphragm was suspected. So then treatment involved an inferior oblique incision along the ribs towards the spine, followed by serial tenting and irrigation. And this was all done without anesthesia.
Count me out. Count me out.
They were like, hey, that warm wine water mixture, just hand me the wine.
I could not imagine doing that without any anesthesia.
Yeah, that's a big incision. So the debate continues about open and closed, with Giovanni di Viago, Italian surgeon to Pope Julius II, who was one of the first to discuss firearm wounds, including those to the chest, originally in 1514 and then again in 1586.
Did I tell you I wasn't on shift. 4 days ago, they had a patient come in with 3 gunshot wounds to the chest. Survived. Made it to the OR. Survived the OR, but I haven't heard an update since then.
Dang.
Wild.
Yeah.
Yeah. We had a patient come in with a gunshot wound to the leg the other day, right above the knee and the thigh. So we called it a trauma because of the location. And he ended up leaving against medical advice before we got any scans to see the arterial damage.
What?
What is right?
Where are you going?
This should have been in my ER moments this week.
Yeah, where are you going, buddy? You didn't remember that?
No.
Okay,
No.
Here's a quote. In this one, you guys can't see the words.
Contrary opinion.
Yeah. So here's a quote from what Giovanni di Viago said. There be many that command to shut in continual to penetrating wounds. The penetrate wound. Basically, they say to shut it. If they said wound be not shut, the air will enter into the heart, and moreover that the vital spirits will issue out by the wound, which thing might hurt the patient. Again, many of the contrary opinion and command to keep the wound open, and if the wound be not large, they say it may be enlarged, that the blood may issue out, affirming that if the blood, which is in the inner part of the issue, out by the orifice of the wound, it may engender many evil accidents and corrupt the inner members.
Back to that corruption.
Yeah.
What is this, black bile now?
No, that's me. So he advocated for open treatment because he didn't want things to be trapped in there, but they're saying like more as a spiritual kind of thing, right? And then also that it can be enlarged so that more can be drained. And then he advocated overall for open treatment, but then allowed closure on the first day if no blood was retained.
Yeah. I mean, all of this does depend on like how much output you're still having.
Yeah. So that was really hard to struggle through.
But you did it.
But I did. I read that Old English and it was hard. Then in 1575, French military surgeon Ambrose Paré described the diagnosis of a penetrating chest wound and attempted to establish standard guidelines to determine opened or closed treatment. He believed that the wound should be left open if there is blood in the chest because if it was closed, the blood would decompose and putrefy, causing fever and other complications. In this case, he would keep the wound open 2 or 3 days while blood flowed out by gravity and then closed when the blood stopped.
So are they using a tube at this point?
Yeah, mostly like reeds.
Yeah, okay.
But not like flexible. Like flexible tubing doesn't exist.
That's fair.
Yeah, but
it's the 1500s. Come on.
Basically think of like your paper straw.
Perfect.
Ugh, gross, it gets like wet. So the idea of removing retained blood persisted in the 17th and 18th century and actually led to the practice of wound sucking.
We're back. I'm out.
You couldn't get away.
I'm out.
Military drummers would often have the responsibility of sucking a wound and then applying compressions and bandages. So here's a description of a written observation of a wound sucker.
Of a wound sucker? Stop it. That's the most disgusting name ever.
One day, he was called to a young fellow, a common soldier who had been run through the breast at the pap and out of the shoulder. After having examined the wound and noticed the length of his antagonist's sword, being well satisfied that the weapon had pierced the lungs and gone quite across the breast, I saw the drummer of the regiment, who was the sucker on this occasion, do his business.
Do his business.
He first sucked one wound, then turning his patient over, he sucked next to the opposite wound. He then applied a piece of chewed paper upon each, and the next day the soldier was seen walking in the streets.
I think my friend would die if it came down to me having to suck their wound. Not I think. You would die. You can be my friend. You would die.
I'm more than your friend.
I'm not doing it.
What?
That's disgusting.
So this technique actually became so popular that many nobles and upper class would bring wound suckers with them during duels. And you may be asking how they actually did this. And yes, they actually did it with their mouths. They did the suction around the wound, suction around the wound with their mouth and sucked it out and then would like spit it out.
Disgusting.
But also remember around this time, when they were practicing when we talked about bloodletting and they were using glasses like cupping to draw out blood, that could also be used in this instance around this time.
Okay.
So
seems a little bit more sanitary.
Yeah. Probably just didn't work as well. So then in 1707, Dominique Annel replaced the human mouth with a silver tube attached to a piston syringe.
Thank God.
But that took 200 years.
It came, okay?
He later invented a cannula, allowing a catheter to be introduced into the pleural space rather than merely applied to the wound margins. Because remember, all this time, these tubes or, using your mouth or cups or anything like that has just been directly entered into the wound or around. Suction is around the wound. Mm-hmm. So you're not going and accessing the pleural space from a different point.
Yeah.
So here's an excerpt from Aphorisms in 1715 in the discussion of thoracic wound management. It is necessary to evacuate the blood from the pleural cavity in a traumatic hemothorax by 1, posturing the patient and by appropriate exercise, 2, suction applied through a blunt-tipped flexible tube perforated laterally, then injection of anticoagulant fluids, enlarging the wound, making a counter incision between the 2 lowest true ribs, 4 finger breadths from the vertebrae, and the inferior scalpel angle using the Stowry directed inferiorly, the incision placed between and parallel to the 2 ribs.
Okay, we're getting somewhere.
Yeah. This shows the ideas of postural drainage, intercostal placement of suction catheters for assisting drainage, and anticoagulation to assist drainage were present at least as early as the mid-18th century.
I gotta tell you, my patient has a hemothorax. I will not be giving them blood thinners. Anticoagulants.
Yeah.
To help with drainage. No, we will not be thinning the thread anymore.
Yeah. 1771, Adams Burkholz then added a reservoir container into the suction line, creating an early aspirator.
Nice. Wow.
So even though there were tons of advancements, there was still a lack of agreement on the optimal initial management of the thoracic. The debate of closed versus open continued. Over the next 30 years, surgeons would close wounds to try and control the hemorrhage, and then create a new wound or reopen the original to evacuate any blood with a cannula.
Yeah. I mean, it's not like they have suction where they can pull it all out, you know?
Well, I mean, they were using pistons.
Yeah, I guess you're right.
Pull it out. So then we're into the Civil War era, and these surgeons are using trocars, a pointed stylus inside a hollow cannula,
Still being used today.
placed in the chest to drain fluid in the pleural space. So here's a description from a Confederate surgeon using one. When the surgeon has recognized such collections as rapidly forming in the chest after gunshot wounds, an early evacuation will be required. An opening for the escape of the fluid should be made at the point which nature indicates, but in case of excessive infusion, any broad intercostal space between the 6th and 8th ribs
That's low.
I know, of the right, or between the 7th and 9th on the left.
We're hitting spleens and livers, baby.
This is not a good spot. Might be selected. A trocar and cannula should be introduced at right angles to the chest and near the upper edge of the rib towards its angle in a line continuous with the posterior border of the armpit.
Yeah. So armpit is what we consider like axillary. And so we do mid to anterior axillary now. It's interesting. They're far back.
Yeah.
Yeah, they're far back in a posterior axillary.
Maybe they thought it would be easier if they were laying on their chest.
I don't know.
Yeah. So it would be another century before this practice gained widespread acceptance and made true difference in combat. But at the same time, Union forces were experimenting with using airtight seals to impede airflow to open chest wounds.
Yes.
Because this is the other portion, is like the air escaping that we haven't really talked about. We've talked about drainage, but not necessarily like when you have an open chest wound, sealing that. So then the first description of a water seal chest drainage system was in 1873 when treating a child with thoracic empyema. Initially, he had 4 aspirations performed, but each time the pleural fluid reaccumulated. So then they opened the abscess cavity and inserted a flexible tube of Indian gum rubber with the distal end in a vessel of water on the floor. The tube drained 1 to 2 ounces of pus daily without any entry of air into the pleural space, and the patient improved.
That's a lot of pus to take out daily. Wow.
Yeah.
But also, why was this kid getting recurrent empyemas?
I don't know.
Interesting.
Kind of cool, though, using gravity and then the pressure of water to keep it from continuously draining.
I agree.
In 1875, Gothard Ballou also used a closed water seal chest drainage system to treat empyema as opposed to the standard rib resection and open tube drainage.
Yeah, sounds a little bit easier.
Yeah.
Wow.
So actually removing ribs
the rib
so that you can access the space. He used a trocar to puncture the pleural space, then introduced a rubber catheter with a distal clamp. The weighted free end of the catheter was immersed in a bottle 1/3 full of antiseptic solution and unclamped, creating a siphon drainage apparatus that allowed pus to flow from the chest.
That's so cool.
So now we're getting into like what you would kind of think of today.
Yeah.
That pulling suction while also keeping it airtight. So he was kind of ahead of his time, this guy that invented this, and emphasized the importance of negative interpleural pressure for re-expansion of a collapsed lung, whereas most of his colleagues were just worried about the infection and not the chances of an open pneumothorax.
Yes. And like you said, I mean, this initially started out in order to drain blood, to drain infections, and specifically the empyema, but now we're understanding there's more than just infection that this can be used for.
Right.
Yeah.
Yeah, and if you get stabbed in the chest, it's more than just like the blood accumulating. Like your lung could also be collapsed.
Yeah.
So like what kind of pressure do you need to leave space for the lung to expand? Yeah. In 1896, a London surgeon published the first English text devoted solely to thoracic surgery. He advocated for closure as a mechanism for controlling hemorrhage as opposed to supporting physiological breathing dynamics. So he's like, close it up so that it stops bleeding, but then not taking into consideration, like we just talked about, the expansion of your chest and the lung and being able to breathe. So now we're coming up on World War I, and you would expect to see a huge jump in the development of these treatments because usually battlefield medicine brings everything forward. Right. And we're talking about large scale deaths happening, gunshot wounds to the chest, very common. Right. But what actually happened is that it was held back by military experience in World War I.
Why?
In World War II, and in the Korean War.
Why?
So it was just not very popular. It was not the go-to treatment.
Sure, but these people are dying and we have a way to save them. Yeah.
It was just, it was not, I also think based on where they were, as far as like how they were treating it and using it, you couldn't move the patients. And so then they're like stuck in a forward operating base medical station. And so you can't like put it in and then move them right now yet. So at this time, the inventions of anesthesia, endotracheal intubation, and blood transfusions should have propelled advancements in treatment of penetrating chest wounds, but that was just not the case. Mortality from chest trauma in World War I was 56%, even with treatments such as needle drainage of hemothorax, wound debridement, wound exploration of foreign body removal, and closure of open pneumothorax with sutures. So they're doing all that stuff. They're removing shrapnel, bullets, anything that's penetrating, and they're cleaning it out and they're closing it, but they're not evacuating fluid buildup.
Fluid, air, whatever it is.
Whatever it is. By the end of World War I, thoracotomy, evacuation of fluid in the pleural cavity, was recognized as an important way to avoid infection by the end of World War I. Plus, the concept of a flutter valve for unidirectional air movement with a drainage tube was spreading, but tube thoracostomy was not widely used for treating hemothoraces or pneumothoraces.
It's kind of sad because like we have what we need to do this and people are dying.
Right. But we're not jumping on it just because it's not a popular, like nobody came out and said, I think it's because it's not standardized.
Yeah, that's fair.
It's like people are still debating open or closed here. Yeah. Right. We don't have a standard treatment to say, go, everybody do this. And since we're deploying so many people and we have limited medical staff, you can't just rely on anybody to do these procedures right now because they're not simple enough. And then you don't have enough surgeons or people with experience to go and do this. World War I was also coupled with the influenza epidemic of 1918, which resulted in a crisis of streptococcal pneumonia and empyema. So we're seeing it in the civilian side as well.
Yeah.
So you have people suffering from chest wounds on one side, and then you have this influenza epidemic. So it's needed.
It's so needed.
In a survey done by the Empyema Commission of 1918, they found that 30% of empyema drainage in base hospitals resulted in death.
Interesting. Just from like poor, I mean, there's so many reasons though. I say interesting. So if you're leaving it open, we're opening it to bacteria. These patients are becoming septic, all of these things. And we don't have sepsis criteria like we do now, where as soon as we see this patient, we're giving them 2 grams of IV antibiotics, Yeah.
Yeah. I also think that they're not focusing on the regaining lung function. And so even if you can remove some of the infection or the pressure, your chest cavity is not in the place to resume your normal lung functioning because of that lack of focus. I think maybe it's increasing the death rate.
Yeah, I think that's fair.
So at the start of World War II, that's where we're seeing this change. Restoration of lung function was the primary goal of thoracic wound treatment, with emphasis on wound debridement and pleural cavity drainage.
Good.
So I think what we're seeing is that there was, even back to Hippocrates, there was a focus on one thing.
Yeah.
But the chest is very complicated. There's a lot of things happening.
Yeah.
Right? So that's why chest wounds are so dangerous. And so they were only focusing on one portion at a time. The full picture was not coming together. It was believed that the chest tube placement to remove blood and replace blood with pressurized air could help avoid the need for an open thoracotomy in patients with persistent interthoracic bleeding, but needle aspiration was still first-line treatment.
It's just interesting because if you have a huge pneumothorax, needle aspiration is not going to get enough of it out. It's
Yeah.
not going to restore normal lung function.
So chest tubes were still only used for brief periods and only in the presence of a continuous air leak. So that they're relying on needle decompression
Yeah.
a lot.
Yeah, which is not enough.
In 1950, it was suggested that draining the thoracic cavity with a more superior approach at the second and third intercostal space might be better. The modern 3-chamber thoracic drainage system was first described in 1952, but was not widely employed, which is similar to how they'd use it today.
Yeah.
In the Korean War, which was 1950 to 1953, mortality decreased to 0.6 to 1.9% of major thoracic trauma patients.
No way.
Yeah.
That's such a drop.
I know. 56% to essentially 1.
Wow.
And then in 1859, the North Atlantic Treaty Organization recommended that for penetrating traumatic hemothorax, the pleural space must be emptied as completely as possible by aspiration. Closed intercostal drainage would be inadvisable.
Yeah.
So that's NATO coming in with a standard.
Yeah.
So this view reflected the mainstream opinions of military surgeons. Also in the 1950s, there was advancements in tube placement techniques, including anchoring the tube to the chest wall instead of the pleura during the lobectomy, along with a better understanding of pulmonary physiology. So basically, putting the chest tube and anchoring it on the chest wall.
Yeah. So like we do now, suturing it to the skin so that it stays in place.
Right. Tube thoracostomy was finally accepted as the standard care for treatment in the Vietnam War. There were also some really great technological developments that improved patient comfort and also improvements in the thoracostomy tube design. So in 1968, a flutter valve was designed to attach to catheters and replace the cumbersome underwater drainage bottles. So the flutter valve invention is key in wartime.
Yes.
Because you just can't carry bottles like around.
No.
This is where we see a big change in the treatment during battlefield medicine, the Vietnam War, and this valve is what we're going to talk about in our case file.
Cool.
Yeah. So this also allowed for better sterility, disposability, simplicity, and safety in case of disconnection. Plus, it allowed for patients to move.
Yes.
So that's where you could see in previous wars, they were hindered by having to keep them stationary with the water pressure and things like that, and not being able to transport them and all these things. So I think that's why it was so slow. They were really waiting for this advancement to get there. So then in 1975, standard size of catheters were also determined. So they used to make catheters in 2 French increments from like 20 to 40. And they were making tons of different sizes. And so people just stocked like tons of different sizes, and was determined that there was really 3 sizes in adults that were standard: 28, 32, and 36. And then 3 in children, which would be 16, 20, and 24. So with that standardization, it allowed for companies to develop those instead of having a wide variety of sizes. And then for people to keep on hand, really the 3 sizes that they needed.
I gotta tell you, if somebody wanted to put a 36 French in me, I'd probably beat their ass. That's massive.
Yeah.
That is massive. Wow.
Yeah. That's kind of where we're going to end today when it comes to history. But in the case file, we're going to dive more into the Vietnam War and why it was so vital.
Yeah, I'm excited for it.
Yeah.
Perfect.
Tell me about today.
So chest tubes did indeed survive, and they're still very widely used, and they are life-saving measures. So very important in today's medicine. Kind of go back through the anatomy just a little bit with some more information in it. So we've been talking about chest tubes this whole time. As I said, they're also called thoracostomy tubes. In today's world, it is a flexible catheter inserted into the pleural space.
Yeah, I didn't mention this, but historically they used like hard PVC pipe and stuff like that. So
without pain medication.
Right. Just could you imagine sticking a PVC pipe?
No.
Oh,
no, I could not. It's used for pleural decompression or drainage, as we talked about, and the goal is to restore normal lung function. And so that's something that we're seeing in history that was forgotten about over and over and over again, is it's not just about draining, it's about that lung function coming back. Indications. So we talked about a pneumothorax, which is your air in between the lung and the chest wall, and this disrupts normal lung expansion. So as you can imagine, bad. So there is 3 different types, which we're going to dive into a little bit deeper now. There's primary spontaneous and secondary spontaneous. Primary is individuals without underlying lung disease. So somebody that's been totally healthy, never been diagnosed, gets an atraumatic pneumothorax. That's your primary spontaneous pneumothorax. Then you have secondary, which happens in individuals with pre-existing lung conditions like COPD, cystic fibrosis, pulmonary fibrosis, etc., etc. So still no trauma, but we know that they have a history that could put them at an increased risk for this. Now remember, we were talking about PJP in the HIV episodes and the opportunistic infections. We said if somebody has HIV and has a spontaneous pneumothorax with no clear cause, we should be thinking about PJP. So just tying that back into this episode.
I want you to know that when we edited HIV and every time we talk about PJP, all I can think about is PBJ.
PBJ.
Peanut butter jelly time.
When we've been talking about empanadas, I've been thinking about empanadas. I'm starving.
That's empanadas.
I'm starving.
Wow. You got to be in an interesting mindset like us if you are taking these words and turning them into food. I guess. We hungry.
And then there's traumatic, which we talked about due to blunt or penetrating chest injury. So we talked about rib fractures, car accidents, penetrating injury. So think about like your knife wound. But then this can also happen during medical procedures like a lung biopsy. So there are some iatrogenic causes of that. Other things that people don't think about that can cause that though is barotrauma. So too much pressure. So like scuba diving or air travel. Not common, obviously, and people are trained in scuba diving to help regulate everything before they go down, but something to think about when your patients come in.
You won't be catching me scuba diving.
Really?
The ocean is not to be explored.
Okay, we're not dropping ourselves in the Great Blue Sea. We're just literally 30 yards off the main.
I don't know about that.
Okay. Then there's the tension, which is the life-threatening emergency. Like we said earlier, air builds up and cannot escape, which just continues to create tension in the chest because that air is coming in and pushing it over, and it compresses the heart in the opposite lung. This is rapidly progressing, very real emergency, and needle decompression is first line. Now, needle decompression, mid-clavicular line, so your clavicle right in the middle, into the second or third intercostal space. Insert the needle with a syringe attached to it, just more so to give you a handle. And then after you get the needle put in, you'll feel like a pop where the air gets released. And then you unscrew the syringe and you let that air come out. And then those patients get a chest tube put in because they just had a tension pneumothorax. I will say some pneumothoraxes can be managed conservatively. If you have a small pneumothorax, your patient is not hypoxic. Typically, we put them on oxygen and we monitor them for a few hours. We repeat their chest x-ray. As long as everything looks okay, they can go home with really strict return precautions. So just because someone has a pneumothorax doesn't mean that they need a chest tube. But if they have a large pneumothorax, a tension, a hemothorax, anything like that, absolutely getting a chest tube. Then there's the question of patients that get a pneumothorax while they're receiving positive pressure ventilation. And this is a critical life-threatening complication. I hadn't really heard of it until one day I was asking about putting BiPAP on one of my patients because they came in respiratory distress. And the attending I was working with was like, never, ever, ever go on BiPAP or CPAP. I think specifically BiPAP though, without getting a chest x-ray and just ruling out a huge pneumothorax because you're going to make it worse and probably kill them. And it's so easy to say like, hey, can we get x-ray to room 2 right now? And they come and I can take a quick look and be like, there's no obvious pneumothorax on that. But this is caused because high airway pressure forces the air into the pleural space. And then it actually rapidly progresses to a tension pneumothorax, as you can imagine.
Yeah, that makes sense.
Yeah. So just like an iatrogenic, so caused by us medical professionals, and very, very scary. Hemothorax, talked about it, accumulation of blood, pleural effusion, accumulation of excess fluid, empyema, pus and bacteria, and then chylothorax, lymphatic fluid. Now, what are the different types of chest tubes? There's large bore and small bore. And so the large bore is greater than a 14 French. That's considered large. So now I want you to think about that 36 French you were just talking about.
That's big.
That's big. These are specifically used in trauma and hemothoraxes and are still preferred in the massive hemothoraxes, even though if you look at current literature, we are finding that the smaller tubes can be used more often than we think. And so you'll see a lot of providers that are trying to push for smaller tubes as we're doing it. But for massive hemothoraxes, you should be going to a large fridge catheter. Small bore or pigtail catheters are less than 14 French, and they're used for effusions and pneumothoraxes. And like I said, you're starting to see these more. We're finding that they can work almost as well, if not as well, and it's considerably less pain. And then there's the indwelling pleural catheter, which you might hear as a Pleurer X catheter. This is used for long-term management of chronic malignant pleural effusion. So pleural effusions that fluid, there's different reasons for it, but one of which is cancer or malignancy can cause recurrent pleural effusions. So if a patient is getting this over and over and over again, instead of placing chest tubes over and over and over again, you can put these in and stay in more long-term. Okay, let's talk technique. I want to let you guys know I'm a fraud. Okay. I have never placed a chest tube. I've watched a chest tube be placed once when I was a student. I have not watched one since becoming a PA, but I did a lot of research on this. So that's where this is coming from. If you're an attending that I work with that is listening to this, maybe you could just skip ahead. Okay.
It'll be fine.
So this is a sterile procedure. Let's be very clear about that. Obviously, you guys know I always bring up sterility in this podcast, but if you think about we're inserting something into the chest wall, into the pleural cavity, the pleural space. This needs to be done cleanly. So sterile procedure, as we talked about earlier, it's placed between the 4th and 5th intercostal space at the mid-axillary line. If you're in a rush, nipple line in males and inframammary fold in females. A lot of people ask the patients to drape their arm over their head in order to have better access to the space. Prepare the skin and drape the area. Procedural sedation if needed, which we'll talk about a little bit more. As someone who's never done this, I'm like, oh, I would love to have my patient under procedural sedation so that I can do this with my time and not be causing them any pain. But then also procedural sedation can cause respiratory depression, and your patient's getting this for a respiratory emergency. So I can kind of understand from a very baseline about how people might not want to do this. Obviously, if there's an emergency, you're also not thinking about procedural sedation. You're thinking about numbing this and getting them being able to breathe again. Lidocaine right at the spot where you're going to cut. Something to note is that you always go superior, so just above the nerve, not inferior or just below the nerve, because inferior to each nerve is our neurovascular bundle, and it's vein, artery, nerve. We call it the VAN, and it's always something you get pimped on in school, so I hope you're ready. And so in order to avoid the neurovascular bundle, you're going to, instead of going just below the rib, you're going just above the rib. Very important. So it's about a 1.5 to 2 centimeter incision that's made with a scalpel, and then you dissect the intercostal soft tissue, because we do have soft tissue that goes in between all of our ribs, by using a hemostat or a Kelly clamp and opening it when you get inside the chest wall. So I don't know if you've ever dissected it, but you just kind of continuously push through and open your clamps over and over and over again. Then you move the clamp over the rib to find the pleural space just above the rib. You perforate the pleura with the clamp that you're using. So people describe hearing, people describe hearing a pop or a sudden decrease in resistance as you're pushing against.
You're like tunneling through.
Mm-hmm.
Yeah. I guess that makes sense because you don't want to puncture anything.
You don't want to puncture the lung.
Yeah.
And then you actually insert your finger into the skin incision to widen the track. And so you just do blunt dissection with your finger. And then you take the chest tube and you clamp it in 2 places. You clamp it at the very tip, which is going to go into the chest wall. And then you clamp it at the bottom so that when you get in there and there's a bunch of blood, fluid, pus, whatever it is, you have it clamped at the bottom and it doesn't just pour everywhere all over you. Mm-hmm. So that's why there's a clamp at the bottom. The position of the chest tube depends on the indication. So what you're doing it for. For infusions, they see a little bit more posterior, and then for like a pneumothorax, a little bit more apical. You're going to insert the chest tube until the last hole is inside the skin. So on the chest tube catheter, there are these holes that are pre-built into it. So obviously you don't want one of those holes on the outside of the skin. So you're pushing it all the way through until the holes are all the way in. And then you suture the chest tube to the skin of the chest wall. There's many different ways that people describe how to do this. It doesn't really matter how you do it as long as it's sutured in so that it's not going to move. They're not going to forget about picking it up perfectly, talking about the suction device that it goes to, and this get ripped out of the chest wall. As you can imagine, that would be a really bad thing.
Is it just at the incision site or higher?
Just at the incision site.
Okay.
Yep. And so it's interesting because this is a sterile procedure, and after you've inserted it into the chest wall, of course, everything in this space is sterile at this time, but after you've inserted it into the chest wall and you make your suture, pretty much after that, the rest of that chest tube is considered not sterile anymore. So the other thing is you don't want this chest tube moving back and forth and causing an infection inside the skin. Then you place a sterile dressing to seal the wound over the site. You connect to the water seal suction apparatus, and then you get a chest x-ray to evaluate the position. And that's it. Yeah. When I was watching the videos to like remember how to do this, I was like, this doesn't seem that hard. Now, there's wrong cadavers who aren't screaming at you and aren't struggling to breathe.
Yeah.
So I feel like things could be very different in an
in real life.
emergency.
Yeah.
Yes. So management of a chest tube, there's 3 different types. There's suction, so like intermittent suction that's typically connected to a wall. There's a water seal, and then there's clamping. Suction is the typical initial management for most indications. So we'll just say that. And then for discontinuing it, depends on the reason that it was placed. So there's no one size fits all for discontinuing or removing a chest tube. If they originally got it for a pneumothorax, you're doing it when there's no air leak visualized, or there's a non-existent or stable mild pneumothorax on chest x-ray. Obviously, if the patient's still having respiratory distress, struggling to breathe, on high oxygen requirements, those are all going to be indications for you not to remove that chest tube yet. If it was placed for a pleural effusion or hemothorax, we're monitoring that output daily. And so you're looking for less than 150 or to 400 cc's, kind of just depends in the literature, over 24 hours. And so nurses during their shift are having to mark this continuously about how much output that they're having. And then there's also, we're looking for output that's serosanguinous fluid, so not just straight blood coming out of the chest tube. So it kind of just depends. And I think even more so, like, look at the patient. Are they more stable? Are they less stable? That's such a good indicator before you even start thinking about these things.
Yeah.
Yeah. Complications due to chest tubes, which I think everyone should be aware of before they get them, is injury to critical structures. So the long thoracic nerve, which if I remember off the top of my head, does like scapular retraction or something like that. The diaphragm, the heart, liver, spleen. So we were kind of talking about the abdominal organs earlier. And the question is, if you're unsure of where you're at, you should go above versus below in order to avoid the abdominal injuries. There's also the chance of an infection, and this includes a superficial infection. So just where we were cutting at, just where there's that little bit of openness around the suture versus a deep organ space. And so sometimes chest tubes can cause empyemas. Yeah, which you can imagine, we're inserting something into your body.
Yeah.
We do everything we can to ensure that it's sterile, but there's never 100% chance that it is sterile. And so infection is always a risk. There is a risk for a parenchymal injury and causing subcutaneous emphysema, so just below the surface. So even though we've come so far in chest tube placements and we know a lot about it, and really very few people are trained in chest tubes. So emergency medicine intensivists and surgeons are trained in chest tubes. It's not a hospitalist procedure. Your OBGYN doesn't know it, you know?
Yeah.
Even though it's like highly specialized and only certain people know it, there's still so many risks associated with it. Yeah, that's
it's
it.
like it's a hard one, you know, because there's so much risk and so many things to consider and all that good stuff. So
yeah, but like someone's going to die from tension pneumothorax.
Exactly. I guess you risk it for your life.
Yes. Which brings us to ethics autopsy. I feel like we have a lot to unpack here.
Yeah, historically, I think that the practice overall wasn't shared. It was very much like surgeons kept it to themselves because they could, read. And then people were just trying to figure it out on the battlefield. That's how you end up getting wound suckers and stuff like that. And like, you're just trying to figure it out, or you're using material that is not sterile and you're trying to just save them from one thing so that they can survive another day, but not necessarily thinking about the whole picture. And I think that's why it's also was so delayed and not introduced in time to help prevent deaths in the world wars, really.
I agree.
Like, it took way longer than it probably should have.
I agree.
Just
100%.
because people were debating about open or closed and not really thinking about anatomy and physiology and how lungs expanded.
Yeah, I agree. I also think there's such a misunderstanding in open versus closed chest tubes. Open chest tubes are just infection and issues waiting to happen. So it's not really an ethical issue, but I do imagine that a lot of people had complications and or died secondary to this not being understood.
Plus the fact that there was no pain control.
Yes. So that was something I was going to talk about. Like, we know in history that there was no pain control, but even in modern medicine, there's a big question of how much do we give? Because in the emergency room, it's a life-saving procedure. And we're going to talk a little bit of the medical ethics behind the consent of that too. But if I don't have time to do procedural sedation and all I have time to do is give you a ton of lidocaine at the site, and it's still an uncomfortable procedure for you, but I save your life, that's hard. Versus, like I said, like procedural sedation can also cause respiratory depression, which can also worsen what the patient came in for. Sure, I would love for you to be asleep because it makes my life easier, but I also might cause other issues because of your respiratory depression, you know? And then, like I said, in modern medicine, there's a question of emergent implied consent in quotation marks versus verbal consent. So if a patient comes in and they can't breathe anymore and they're not with it enough to answer your questions, when we notice that they have something like a tension pneumothorax or something that we can place a chest tube for and it helped them in the emergency room, we have implied consent to help the patient, which makes total sense.
Yeah.
Until you have a patient that didn't actually want it. I had a patient a couple of weeks ago who came in, ended up unfortunately not doing so well and needed to be intubated. And she came from a facility. And before we went to intubate, I asked someone to call the facility and check her code status because we didn't know where her paperwork was. We didn't really have time to find it, blah, blah, blah. We had nothing in our system. When we called, they told us she was a full code. I intubated her, we sent her to the ICU. And then I got a call from the facility from one of the doctors that worked there that told me she was a DNR DNI. Now, there was nothing I could have done in that situation. We did the right thing. But if the facility wouldn't have answered, I still would have had implied emergent consent to intubate this patient.
Yeah.
Now, it ended up working out because the patient's power of attorney changed her code status to full code, which is a whole nother ethical discussion. The patient is still intubated in the ICU right now, is doing okay, right? But that's a whole nother ethical consideration of if your power of attorney should be able to overturn your code status. I personally don't think so.
I don't think so.
I don't think so. I very much stand against it.
As long as you made your code status while you were mentally sound.
Yes.
I think you shouldn't be able to change it.
I agree. But yeah, just this idea of consent, you know, we're looking to save lives, but some people, they are ready to go for whatever reason and they get to make those decisions, but it does get sticky in the emergency room in some of these true emergencies.
Yeah, for sure.
Yeah. Cut it or keep it.
Oh yeah.
Keep
it.
For sure. This is so cool.
Yeah.
It's so cool. I think needle decompressions are so cool. I've never done one of those either, but the distress that you find these patients in, and then you all of a sudden they can breathe, or, you know, their fluids are completely overloaded and you listen to them and you can hear crackles everywhere and you're like, this is bad. And you can do something to help them, keep it.
Yeah.
Yeah.
For sure.
And it's one of those things in history that you're not like, oh, this was such a shitty way of getting here, but I'm glad we got here. Not a ton of like historical, ethical issues.
Yeah. I mean, besides the delay, but I think a lot of that also had to do with engineering very small medical devices and understanding like pressure and some of those other things that really helped it move along. So I think you can't really blame the scientific delay, I guess, as a reason to not keep it. I think it's still a life-saving procedure.
I agree. And then that brings us to our listener question, which I'm going to answer. If you were told you needed a chest tube right now to save your life, would you want a full explanation of every risk, or would you say, just do it?
Just do it.
Just do it, for sure. If I need a chest tube right now to save my life as a medical professional who knows why we're inserting chest tubes, I don't give a flying fuck about those risks. You insert that chest tube right now. Let's go. Now, would I let the med student insert my chest tube? Probably not. I'm sorry.
Sorry, med student.
I let med students do a lot. This would not be one of them.
No, thank you.
No.
Yeah.
But you agree. Just do it.
Oh, yeah, for sure.
Don't tell me about it. Give me some pain meds. Let's go.
Lock and loaded. Let's go.
Yeah. But what do you guys think?
Yeah. Let us know. All right. So that closes us on chest tubes.
Yeah. Crack in the chest.
Yeah. And so we're going to talk about the Vietnam War and how chest tubes developed and that super awesome invention and where that came from. It actually came from the same guy that invented the Heimlich maneuver. His name is Heimlich.
Can't imagine naming after himself.
Right. So we're going to talk more about that. Also going to touch on nursing and the impact that it had in the Vietnam War. So that's going to be cool.
Sweet.
Yeah.
Sweet. All right. Ways to support us. It's easy now. Check out links in our show notes, links in our bio. You can go to our link tree and see everything. We do have a deal now with Riverside if you want to check it out. If you have any interest in podcasting, you are always welcome to reach out to us and ask us a question. You know, we're figuring it out as we go, but we have figured out a lot so far. And if you're interested in doing it, we have a link to make it a little bit cheaper for you.
Yeah.
So listen anywhere you get your podcast, but you can also find those links in our show notes. And best way is to leave a review, comment, share our podcast, and keep listening.
Yeah, keep on listening, guys. We appreciate you. Also, if you have an idea for an episode or a case, go ahead and DM us on social media. And then if you have a story that you would like us to share on the podcast, go ahead and send that in. And we're really hoping to start those episodes as soon as we can get a few stories going.
Yeah, we've been talking a lot about, like what's next? What's the next thing that would be really interesting for people? And obviously, we want to get big people on that are more experts than I in some of these conversations. But I've also talked about like a cases and cocktails where we could do an Instagram live and set up some cases and kind of just have a few drinks with people and walk through things. You can see what it's like from the medical side and what things we're concerned about. That's really nice because I'm concerned about things from the emergency standpoint. So,
Yeah.
yeah. And that's it. Class
Well,
is dismissed.
stay safe
Stay curious.
and don't try this at home.
Unless you own a bone saw.
Don't be trying test chest tubes at home.
No, that would be what I definitely would not.
Don't do that.
Bye, guys.
Bye.
This podcast is for educational and entertainment purposes only. We discuss the history of medicine, not your personal medical situation. Nothing you hear on this show should ever be taken as medical advice, diagnosis, or treatment. Some of the information discussed may be incorrect or become outdated over time. We do our best to stay current with medical knowledge, but medicine changes quickly. Additionally, because we do not work in every specific field we discuss, there may be times when we misspeak or misinterpret information. We're all human and we're doing our best for the podcast. Every medical case is unique, and your health decisions should always be made in consultation with your own qualified healthcare professional. If you have any questions or concerns about your health, please reach out to a licensed provider who can give you guidance based on your individual needs.